Welcome back to the Neurophilia podcast. I am your host, Nupur Goel. In today's episode, A Talk Between the Mind and Heart, we will be discussing the interplay between neurology and cardiology. The term neurocardiology was first coined by Dr. Nadelson in 1985. The heart's effects on the brain have been well established over the past few decades. 15 to 1/3 of all strokes are caused by cardiac diseases such as atrial fibrillation, CHF, structural heart disease, and endocarditis. In addition, an estimated 6 to 30% of patients that undergo a cardiac procedure will experience perioperative neurological injury. And most significantly, 50 to as high as 80% of cardiac arrest patients will suffer from cognitive impairment because of cerebral hypoxia. More recently, the focus has shifted towards identifying the brain's role in cardiac function. Research performed in animal models suggests that the insula, hypothalamus, and thalamus play direct roles in cardiac function. Various other studies show that an acute stroke or hemorrhage can actually result in EKG changes that persist for days to months on end. For a more in-depth review of statistics and studies mentioned in this podcast, check out the episode's description for more information. In an article titled Heart-Brain Interactions, Neurocardiology or Cardioneurology Comes of Age, there is a line that reads, "The neurologist cannot ignore the heart, and the cardiologist must consider the cerebral consequences of cardiac disease." And while I think this quote wonderfully summarizes the connection that exists between the mind and the heart, it makes it seem like the interplay between neurology and cardiology is more of an obligation rather than an opportunity. The purpose of today's episode is to highlight the positive and mutually beneficial relationship that exists between these two fields of medicine. To accomplish this, I have with me vascular neurologist Dr. Buletko and special guest Dr. Ankur Kalra. Dr. Ankur Kalra is an interventional cardiologist, medical director, and founder of the nonprofit startup makeadent.org. He is the host of a fantastic cardiology podcast show, Parallax. Dr. Kalra, welcome to the Neurophilia podcast. I want to thank you as well as Dr. Buletko for joining us for what is sure to be a very exciting episode.
Nupur, thanks for having me. Congratulations for your new podcast, and I'm delighted and excited to be here.
Well, we're delighted and excited to have you here as well. And so I don't want to waste another second. I really just want to jump into this conversation. And as you know, I discussed earlier, it's been well described, this connection that exists between the brain and the heart and vice versa. And so, one can just naturally assume that neurologists and cardiologists must be well versed in both areas to be able to properly manage the pathophysiological relationship that exists between these organ systems. And so the first question that I have, Dr. Kalra, as an interventional cardiologist, what are the neurological complications that you often consider in your practice?
It's an important question that you ask. And it's actually one of the most important neurological complication which we get, for lack of a better word, we get judged on is stroke. And I think peri-procedural stroke is an important outcome not only for not only for our patients, it's an important outcome as a quality metric. And that is garnering more and more attention as we switch, from coronary procedures to actually procedures addressing heart valve conditions, particularly aortic valve stenosis. And we now have devices which will actually try to mitigate stroke as a complication in patients who have complex valvular disease. But stroke is one of the most important neurological complications that we focus on as interventional cardiologists.
Absolutely. And to sort of look at the other side of the coin, Dr. Buletko, as a vascular neurologist who primarily treats those strokes that occur in patients, what are the cardiac complications that you often consider in your practice?
Yeah, Nupur, thanks again for having me, and it's great to get to talk to Ankur for this time that we have here. And I definitely agree. There is so much interplay between what I do every day and our cardiology teams, and it's sometimes I feel like I can't go a day without talking to a cardiologist. And so I would say that aside from stroke, which we could talk about for a whole podcast between the interaction between stroke and cardiology and stroke, I would say that there are a lot of other considerations that interplay between neurology and cardiology. Even if we take dysautonomia and different autonomic syndromes that can lead to syncope, we have a lot of clinics throughout the country that focus on neurocardiogenic causes of syncope, and they work very closely together. We do a lot of medication management. Cardiology and neurology are both very much primary care in a lot of patients' lives. And so managing similar medications, managing similar comorbidities. And then I would push it one step further to say that there are some systematic diseases that affect both the heart and the brain. And so we're managing kind of the end stage diseases that didn't even start primarily within the heart or the brain. But certainly I know that we're going to talk a lot more about stroke and the heart during this podcast, given the background of both of us. So I'm excited to dig into that a little bit more.
Absolutely. And based on what you said, I do actually have a follow-up question. You mentioned that, it seems like not a day goes by that you aren't in contact with your cardiology colleagues. And so, this question goes for both of you. How often are you in contact and communication with each other in terms of managing patients?
I mean, I can answer that first up. There is a lot of overlap. I think if you consider pathology if you want to focus on pathologies that we see together, I think there's a lot of overlap in disease states that we see and we take care of. I think the one that comes to mind, like right off the bat, is a patent foramen ovale, and the decision on when to close and when not to close is a really important one. And I do think that you need, right front and center, you need a good neurologist on board for you to make that decision for a patient, because it's a complex decision. And the reason I say that is that you can't close every PFO, right, that you would see, and you would end up closing up a 1/4 of the world's population if you do that, because that's the incidence of a patent foramen ovale. So a lot of nuance goes into closing one. And there are downstream consequences of closing one, because studies have consistently shown that in patients who do end up getting the device, and this is statistics from population health, the overall risk of supraventricular tachyarrhythmias in the patient population that had the PFO closed is actually higher compared with their controls. So it's not a casual decision that you can just make, close every PFO. That certainly is not the case. You do need a neurologist on board for you to make that decision. And I do think that payers also ask for a collaboration between an interventionist and a neurologist when you're making that decision. So I think that is like numero uno, I would say on the list when I think of a neurology colleague. The other one, certainly the big one, is atrial fibrillation, which again there will be a lot of overlap and common patients, particularly in patients who are at high bleeding risk. Thankfully, with direct oral anticoagulants, we've mitigated the risk of intracranial hemorrhage, which is a complication that none of us wants to see. So that, certainly in patients who are not candidates for percutaneous intervention and need lytic therapy for acute myocardial infarction, that's another important subset of patients in which you do need a neurology colleague, on board. Certainly, I certainly need one. And then we can get into dysautonomia. We can also get into broken heart syndrome, where you have the central nervous system affecting the heart. But I'll stop here and I'll let Blake take on from here.
Yeah, Nupur, real life examples. I am in the hospital quite a lot, and I also am in the clinic quite a lot. And I can tell you, whenever I'm on hospital service, it's every day. I interact with a cardiologist on the stroke service every single day, and whether that's co-managing a cardioembolic stroke patient or managing cardiac complications that are due to stroke, again, going back to this stroke heart syndrome that we're talking about a little bit, where it's been recently described as a nice publication just in September of last year, this kind of looking into, again, the stroke heart syndrome. And I know we talk a lot about, and neurologists probably blame the cardiac complications for most of what we do from a stroke standpoint in a large percentage of patients that we deem to be cardioembolic. But really, what we haven't focused on in some time is what the strokes and what, from a brain standpoint, what effects those are having on downstream complications from a heart standpoint. And so it's been really nice to see this kind of re-looked into in the recent past. And I would say in the outpatient clinics, I probably talk to an interventional cardiologist once a week. PFO closure is definitely one of them. Left atrial appendage closure devices would be another big one that I communicate. And then sometimes it's just medical management, or it's that the patients view both of us as primary physicians in their overall care. And they always want to make sure anytime that I broach something to them, that their cardiologist is on board with this. And I think it's absolutely wonderful that the patients really own their cardiologist and own their neurologist as important members of their team. And so we can do right by patients by making sure that we're communicating together.
Absolutely. Well, thank you both for your insight. And I actually wanted to go back to something that Dr. Kara mentioned very briefly, this idea of the broken heart syndrome. And I feel the need to bring it up because it's something that is obviously widely reported on. And even Dr. Kara, you yourself published this amazing article in JAMA, titled Incidence of Stress Cardiomyopathy During the Coronavirus Disease 2019 Pandemic. And in this article, you sort of talk about the increase in broken heart syndrome due to the increased psychological, social, and emotional stressors that the pandemic brought for so many individuals. And in reading that article, it really inspired me to sort of try to figure out what the brain's role is in cardiac dysfunction, especially related to this disease. And what I found was pretty startling, that, as you mentioned, the pathophysiology of broken heart syndrome is this idea that stress, whether it be psychological, emotional, leads to activation of the sympathetic nervous system, and the release of catecholamines can actually lead to damage of myocardial tissue. And, when researchers have been looking at sort of the coexisting morbidities that patients have, a large part of that relates to the brain. And so I saw something that as high as 30% of patients that have this broken heart syndrome actually have coexisting psychiatric conditions, and about 7% of them also have coexisting diseases of the nervous system. And so I think everything that has been mentioned thus far is just a testament to the connection between the brain and the heart, and this idea that you really can't treat one organ system without thoughtful consideration of the other. And I wanted to move on now. Both of you have sort of talked about the necessity of the other profession and being able to do your job well. And so I wanted to know from your perspective, what do you define as successful collaboration between providers?
I can answer this. I think, it's an interesting question. I think successful collaboration is when you can wholeheartedly disagree with one another and yet be respectful of one another. That's how I would define it. And the reason I say that is that, hopefully for the vast majority of your patients that you see together, you're on the same page. But there will be situations that you'll encounter in clinical practice where you passionately agree on something, and you have your own set of data to back that decision, and then your colleague from the other specialty would be absolutely convinced about another alternative pathway of managing the same patient, but in a different manner. And you sort of have the insight of disagreeing with that approach, but yet being completely respectful of that decision, and then let the patient make the best decision for themselves. That situation occurs not infrequently in clinical practice. And I think that if you have attained that level of security and comfort in your own as well as your colleague, I think that is truly a really good collaboration.
Absolutely.
What do you think, Blake?
I agree with everything that you said. I think at the end of the day, if we could call a successful collaboration between the two of us something that benefits patient care. I think that is all we can ever ask for. I think if a patient it feels comfortable with their team, and if what we're trying to do for that patient ultimately is enhanced by the interaction between you and I think that's all that I could ever ask from a successful collaboration with a colleague of mine. I think that there's always two sides, and again, the cardiologists remind us that that the brain wouldn't do much if the heart wasn't pumping blood there, and we try to remind our cardiology friends that from our side of things, that again, the heart causes a lot of damage to the brain, and that the brain is the essential being of who we are in the body. And so I think it's a beautiful interplay between the two of them. And so I think communication between the cardiologist and the neurologist, I think, is really important. And that collaboration really comes down to, does the patient feel like they're benefiting from having both people involved, and is a uniform agreement ultimately made so that it's going to best benefit the patient?
Yeah, I think philosophically though, right, like just to end this on a philosophical note, I do think that all decisions in life should be made from the heart, not from the brain. But that's me. That's just how I think. So,
Hunter, every single PowerPoint and every single thing that I do, I always put the awkward Yeti, brain and heart, if you've seen the comics or the memes. And it portrays, I'll tell you what, it portrays the brain in a way that is very boring and very structured. And I'll tell you what, looking at some of those, I would also go with the heart 9 times out of 10.
Well, yeah, I mean,
don't tell anybody I'm saying this as a neurologist, but I absolutely love those memes, and I find them absolutely fascinating to really think through.
Yeah, I mean, like art comes from the heart, poetry comes from the heart. So many philosophies come from the heart. I mean, you certainly use the brain to write them, but I'm just biased, but that's my take on life.
We can agree that you need both of them to be very well-rounded and have a holistic approach.
Yep, absolutely.
Absolutely. Well, I absolutely love what you said, Dr. Kalra, about this idea of, even in disagreement, being able to truly respect your colleague. And so the follow-up question I have to that, because I think oftentimes, for medical students as well as young doctors, you sort of worry about coming into conflict with consultants when it comes to patient management. And so I wanted to know, from your perspectives, how do you go about disagreements when it comes to patient management?
I think, for me, what I would do is I would really put myself in my colleagues' shoes in terms of trying to understand where they're coming from. If feasible, read the literature myself and try and garner data points which they're referring to, and truly try to understand their perspective, and weigh that perspective against mine, and then try to decide what I would do if I were the patient. That's how I think of things. So truly putting yourself in your colleague's shoes, even though I know it's really hard to do, but just being on the other side, so to speak, and then sort of weighing that against what because I mean, you only have as much information and knowledge about the other field unless you truly put the time to read the literature. And then being really compassionate and empathetic, and putting yourself in the patient's shoes, and trying to decide what would be the best for them, I think is the best way to navigate disagreement. And at the end, like I said before, even if you still disagree, just being absolutely respectful of the colleague, because that disagreement is only on one data point, but that disagreement is not personal. So being respectful of who they are as a person and as a physician, I think is truly important. And that comes from the heart. Like that is genuine. So if it's genuine, that should not be supplanted by what you think about a particular patient in a particular clinical scenario. So that's usually my approach. on these cases.
I think that's beautifully said. I couldn't agree with you anymore. And, you can take a different spin on this and say that sometimes disagreement leads to advances in our fields and advances in the questions that we're trying to ask. And so I think whenever there is this discrepancy, it makes us question, well, where's the gap in literature? Where's the gap in evidence-based medicine? And oftentimes what that does is that brings us closer together, because then we collaborate and we say, how can we address this? Because this is a common theme. We don't have concrete answers between the two of us. How can we come together and make this better for our patients? And I think at the end of the day, that's our responsibility, is to our patients, to put all the information in front of our patients as we can and help guide them into a decision that ultimately they're making. I think it's really important to allow our patients to have as much autonomy and understanding of what's happening for their own medical care as possible. And I think as long as we are picking up the phone and we're calling each other and we're emailing each other and we're messaging each other, really, I haven't had too many conflicts that weren't pretty quickly resolved, because ultimately, when it comes back to being very patient-centered, we all want the same thing. And that's something that we can always agree on, and something that should always be a focus of what we're doing.
Yeah, like I always, a good allegory here is like in the, the coagulation cascade, there is a final common pathway. So, our final common pathway is excellent patient care and evidence-based patient care. So I think as long as we, you and your colleague are share the final common pathway, I think, all disagreements find a home. And, disagreements have led to new questions, and new questions lead to new information, and that's how we garner new knowledge and advance the field. So, I think as a researcher, that's fertile ground for new ideas. So, always welcome disagreements in clinical medicine.
Absolutely.
Yeah.
Well, I think it goes back to that idea of it being, part of the art of medicine, how you're able to respectfully disagree in the name of patient outcomes. And I think the way that you guys both put that was just beautiful. This idea of it being a fertile opportunity, and it's all about the way that you view things, right? You can see it as a conflict, you can see it as an issue, a hurdle that you have to overcome, but you can also see it as a beautiful opportunity to advance the field of medicine. So to sort of shift gears, Dr. Kalra, the focus of our first season of Neurophilia is this idea of neurophobia, the fear of neurology that exists not only in neurology, but also specifically in other fields of medicine. And so, something that I wanted to ask you was, in your field, being an interventional cardiologist, have you experienced neurophobia?
I have. I think whenever you have an unresponsive patient on the table, it's a very uncomfortable feeling. I mean, the first thing that comes to the mind is, did I flick plaque, which went, upstream and caused a disabling stroke. More often than not, we've gotten, as a field, I think we've advanced in terms of, how we use our catheters, how we try and maintain, good clinical practice, in terms of the ergonomics of how catheters are used and how they're manufactured and how they're developed. And we're very mindful of, talking to the patient. I am not a big fan of using sedation, actually. I think it's mostly in the US that we use sedation. I think everywhere else in the globe, opioids are not used for moderate sedation. In part because of your ability to monitor neurological status and change on the table, and also in part because of cost and other drug interactions, particularly with fentanyl. I do know that most of the colleagues do use it in the US. But I think the one thing which really scares us as interventionalists is change in mental status on the table. That's not a good day for us in the lab. So to answer your question, the answer is yes. And then the very first thing that we do is code stroke. Just call our colleagues and have them evaluate the patient. They could say, come on, guys, I am completely fine looking stupid. I have no problem looking stupid. My ego is at the door as soon as I enter the lab. So I'm I'm completely comfortable in looking stupid, as long as, we've crossed all the T's and dotted all the I's and made sure that the patient is fine. More often than not, actually it's just sedation, that ends up being the culprit for why there was a change in neurological status. You'll be surprised, particularly with an aging population, how different patients react to sedation that we use during procedures, and that's in part because of how these drugs, the pharmacokinetics in terms of the body fat and metabolism, how these drugs get metabolized. So you'll be surprised, particularly in the aging population, how these drugs get metabolized, that different people have different thresholds. But again, whenever in doubt, just call your colleague and make sure everything is okay. That's what I do. So the answer is yes, I am neurophobic.
Well, and it's important to be able to recognize that. And I appreciate your honesty and vulnerability in admitting your neurophobia. But, the second part of what we try to do on this, on this podcast, on this platform, is find ways to help combat neurophobia, right? We want to find a way to eradicate it, not only in medical students, resident doctors, but also attending physicians who have been practicing for a long time. And so, the question that I have for both you as well as Dr. Buletko, how can neurologists do a better job of connecting neurology to other fields of medicine and working to dispel neurophobia?
Nupur, I can start a little bit there and kind of piggyback off of a little bit what was just described in this very chaotic, hectic moment where a patient's unresponsive during a procedure. And one of, I'm sorry, I'm going to steal your host role for a minute, but I have a question that I was hoping to ask Ankur, and that's, has your view of that moment changed over time? As we have advanced the field of neurology, as we can now do more than what we could do from a interventional neurology standpoint, and we can take a patient with an LVO from your table to our table and recanalize an intracranial vessel. Have you been swayed at all of the advances from a neurology standpoint and a stroke standpoint? And do you have any more? Is it still as neurophobic to you when you have those as what it was maybe 5 or 10 years ago, or has your view on those instances changed over time?
Blake, I think when it happens, I think that the first 1 or 2 minutes are still very chaotic for me, because in terms of a proceduralist, I'm just going over the steps that I took until we got there. So, and trying to identify, what lacuna may have occurred that we are here. So, I'm running over the algorithms of how much sedation was given, when was the patient last responsive, what catheters did I use, which vessel I crossed, what did I do from a procedural standpoint. So I am actually running my checklist as you guys are running down or up the staircase to come to the patient. That's what I'm doing. So the initial 1-2 minutes are still very chaotic for me and very uncomfortable for me. But I think, God forbid, if we do identify that there is a stroke, I agree with you. I mean, I have gotten very comfortable in the advances that neurology has made, particularly interventional neurology, in terms of your ability. And this has happened to me, with one of my patients. Like, the patient was whisked away to the neurology lab within minutes, from the cath lab to the neurology lab. And within a matter of 30 minutes, we actually had a diagnosis, and we had, the lesion taken care of from an interventional neurologist. And the patient was then, eventually you're not going to take the patient back to the cath lab to, I usually, and you can correct me if I'm wrong, but my rule of thumb is I'm probably going to wait at least 6 weeks before I'm going to re-intervene, at least 4, if not 6 weeks, following an acute stroke. But, patients have completely recovered neurologically and have done well and have been discharged to be brought back in perfect health. So, as anxiety-inducing and as nerve-wracking and as adrenaline-generating as that episode is, and the initial, like I said, couple of minutes are still that for me even now. I do have a lot of faith and solace in the advances that have occurred since, because I think that the patient is really, I mean, is the recipient of cutting edge care that is delivered because of this collaboration. So thank you for do what you do. It's incredible.
And just to your point too, I mean, that initial meeting, you going through that checklist in your mind while we're running your way, I can't tell you how important it is for us to get that information from you in real time. I mean, that drives every single thing that we're going to do for that patient from that point on, from our standpoint. So I can tell you, we're talking about communication amongst cardiologists and neurologists, and in that acute moment, I can't tell you how important it is to have that very, very, very imperative information in your checklist that you just went over. You just reiterate that back to us, and all of a sudden that allows us to move forward with that patient in a way that we're not digging through the chart, we're not digging for information, we're not guessing as to what might have happened. And so I think you really want to see collaboration. It might feel like we're going to take this patient, do a quick handoff, but that handoff that might only take a couple minutes, and that checklist that you just went over, that changes everything for the patient, that changes everything for our timing. And we can't thank you all enough. And so I know that I got a little bit away from Nupur's original question, and we'll get back to it, but I think that it goes both ways. And that information that we get, even if it's chaotic and hectic, it always seems a little bit more prepared to us than that. And we all know that you are all very, very good at what you do. And so we really respect that, and we use that. And I think together, that's what ultimately leads to better outcomes for our patients. And so we can get back to, I think, the original question at hand, which is how can we better help in not just acute situations, but in everyday situations from a neurology standpoint to help collaborate and interact with other specialties of medicine and kind of help dispel some of this neurophobia.
Yeah, and I would like to add one more point here, and that is, I mean, you can never know enough about your patient, is what I was taught by my mentor. So, know as much as you can, whether it's past medical history, which, of course, is relevant to what you're going to do from a procedure standpoint. But also, I think, in terms of when you're running through the checklist, I want to make sure that I'm prepared so that when my neurology colleague is here, they're not wasting time running through what we just did. I mean, they should have every intricate, minute detail. And I think that just comes, I think in part that just comes in being detail oriented, or being fastidious, which I think is, you can't be fastidious enough to be in medicine. That's my rule. Like you can never know enough about the patient. There's always more to be known about the patient.
For everyone who's listening to this podcast, pause it, rewind, re-listen to that. If everybody could keep that in mind, I'm speaking from a pure stroke and neurology standpoint, how great would it be if everybody had that approach whenever we met them with an acute situation like that? So thank you so much for that. I thought that was really great, and I hope everyone was paying attention.
So to get back to the question at hand, this idea of neurophobia, we're having a lot of great conversations, and I don't want to move us along too quickly, but I do want to be respectful of everyone's times. So Dr. Kalra, from your perspective, how can we as neurologists, Dr. Buletko being a current one, me being a future one, how can we do a better job of helping to dispel neurophobia?
I think education, and so education could be multifaceted, right? I mean, I think just first of all, I think neurologists are crazy smart people, because a lot still depends on clinical acumen and clinical training. I'm not trying to take anything away from any other specialties, but I mean, I think, particularly with, cardiology, everything has become so objective and image-based. I mean, we talk about having lost the skill of the physical exam. For example, identifying valve lesions by just, like my father, for example, can tell you the grade of aortic stenosis severity just by auscultating. He does not even echo. I can't do that, because he trained when there was only M mode. And now we have, we have 3D echo, obviously, but we have TEE. But more important, more than that, we even for a transthoracic echo, we have strain, we have, color Doppler, we have spectral, we have imaging advancements which were not existential at his time. So there has been this attrition in physical exam skills. I think the one specialty, I think, so inside of medicine, maybe rheumatologists are still very clinically focused, right? And I think, neurologists, the fact that you can examine and you examine the patient, I think neurologists are still the clinicians who examine the patient the best, in my opinion. Like in 2023, if I were to think of two specialties who examine the patient the most comprehensive fashion, I think it has to be neurology is on top. And the fact that you can come up with a differential of where the lesion is going to be before you take the patient to imaging is still a skill set which has not attritioned over time. So I think that to me is very attractive. Is cognitively very attractive, to me as a physician. So I think if you can slowly, through osmosis, maybe disseminate that knowledge to your colleagues so that they can look, or they can be at least as smart. Begin look. I feel very stupid in front of a neurologist when you're in your differential coming up with where the lesion is going to be, and it's like, that's pretty attractive. Why can't I do that? So and I was like, and then I actually have tried to go back and look at the homunculus, that the popular homunculus diagram from medical school, and it's like, what, I'm way too far out into cardiology. I'll just leave that to the neurologist. But if you can, through osmosis, somehow disseminate that knowledge to your colleagues, I think all of us will feel a lot more secure in front of all of you. But yeah, I think I think if you can educate your colleagues about the big things to worry about, in terms of lesions and telltale signs of some of the most common lesions you see on a day-to-day basis, I think that would be very helpful, for all of us. I don't think I can think of anything else to mitigate neurophobia. The other thing that you can do is start not wearing bow ties, because they're very intimidating. A bow tie with a white coat, that person's gonna be a neurologist, and it's so intimidating. It's like, and then the only thing you need is those round glasses, and that's it. then I start thinking about my time in Boston, but that's it for me. I think that's the answer that I would give to that question.
Ankur, I don't wear bow ties or glasses, but you have me wanting to do both of those now. I'm trying to dispel this vision of neurologist, and here you are just putting it up on a pedestal. And now I feel bad that I don't wear bow ties and I don't wear glasses, but I have several colleagues who do. So thanks for sharing that.
And Dr. Kalra, just to echo what Dr. Buletko said, I think education is such a phenomenal answer in it. And it reminds me of this quote that, it's one of my favorite quotes of all time from Nelson Mandela. I'm not sure if either of you are familiar. Education is the most powerful weapon you can use to change the world. And I think that if we take the time, in our fields, you mentioned feeling this idea of feeling stupid or feeling like you're not knowledgeable enough when it comes to neurology. I'm sure Dr. Buletko can say when it comes to certain aspects of cardiology, he would also feel uncomfortable and out of water. But I think a large part of progressing this sort of collaboration and mutual respect in these fields is vulnerability, and being able to lower your guard and say what scares you about a field that you often have to interact with. So I really appreciate your vulnerability, and I really appreciate you taking the time to get educated, but also to educate us in the process.
And it goes both ways. As a stroke neurologist, I have to preface by saying that we understand that the heart is basically just a pump with some electricity. So it's much easier to figure out than the complex brain, right? But with that being said, we poach a lot of cardiac literature. And we extrapolate a lot from what you all have done and the advances that have been made in the cardiac literature a lot for cerebrovascular disease. And so we wouldn't have made the advances that we've made in stroke care, I truly believe, without the cardiologists being ahead of us. And I say that in a very complimentary way, and we very much appreciate everything that you all do to advance your own field, because we all benefit from that. And ultimately, that means that all of our patients benefit from that. So I see this every single day, and I talk to all of our trainees every day about, hey, where did you get that evidence-based medicine, Dr. Buletko? And I say, well, don't tell anybody, but this came from cardiology, and we're just kind of extrapolating it, but give us 20 years and maybe we'll have the same thing in stroke. So we joke about it all the time, but I mean, what you all have done in cardiology has really allowed us to advance our own field, and I think the collaboration is really great.
Yeah, no, I think cardiology has truly been at the forefront of evidence-based medicine, and I think in part that is also true because of the sheer burden of disease, right? So it's not as hard to find patients or to enroll patients in answering all the questions that you encounter on the bedside or clinically. The one thing about and by the way, I mean, cardiology and the heart is like the analogy that I give is like, think of the heart like a house. So you have plumbing, you have electricity, you have bricks, and you have doors. So plumbing is the coronaries, electricity is EP, so the cardiac conduction system. The bricks are the heart muscle, and the doors are the valves. And it's just an interplay of these four things, and that's it. That's all cardiology is. I mean, that's what I tell patients, and even medical students or residents. And certainly the brain is a lot more complex than that. It's not as simple as the heart. But I think the two aspects of cardiology where we have led, I think, medicine in general is one, our ability to garner data using RCTs, and also our I'm trying to think what the best word is. I mean, truthfulness in terms of reporting our own outcomes, I think, which I think is putting us at a vulnerable stage, but then also making ourselves very accountable of the quality of care that we are delivering. I think cardiology has truly led medicine in those aspects, and if other specialties can extrapolate or emulate, I'm sure it's going to be the best for our patients.
Absolutely. Well, Doctors Kalra and Buletko, it has been such an honor and a pleasure talking with you both today about this relationship, this beautiful relationship that does exist between neurology and cardiology. So thank you for your time. And before we wrap up our conversation, I want to ask you, Dr. Kalra, about your no-brainers. And these are going to be 5 rapid-fire questions that you can respond to with 1 word or 1 sentence maximum. So are you ready to go?
I'm ready to go.
You're ready to go? Got your bow tie on and everything. First question, what are you most looking forward to in 2023?
My novel that I'll be finishing and making it ready for publication in 2024.
What is it going to be called?
It's called Pralaya. So Pralaya is a Hindi word for the Great Dissolution, and it's inspired by the Bhagavad Gita. It's a love story set amidst war in 286 BC. So
wow,
that's what I'm looking forward to.
And if you guys are looking for another great book by Dr. Kalra, make sure you check out Ibadah. It's a great read. I own it myself.
Oh,
okay, so the second question that I have, what is the greatest piece of advice you have received in medical training?
The first one I already shared, right? You cannot know enough about the patient. And the second is never say never.
Okay. What is the best part of your job?
My ability to connect with my patients emotionally when they are at their most vulnerable. I feel it's a privilege which is rare and is the best part of my job.
Beautifully put. How would you describe the field of neurology?
It's a cognitive superpower. That's how I think of it.
Okay. And the last question I have for you.
Yeah, you guys have a lot of you guys have a ton of my respect, just so you know, because I don't think I can do what you can do.
Last question that I have for you, Dr. Kalra. What do you enjoy the most about neurology?
The ability to, purely based on clinical exam, to mathematically derive the lesion blows my mind every single time. And that's what I like the most about. That's what I'm not an enviable or a jealous person, so I get inspired. That's what inspires me the most about a neurologist. Yeah.
Absolutely. Well, thank you so much for your time, Dr. Kalra, as well as Dr. Buletko. And if you guys are looking for a truly excellent medical podcast, please check out Parallax by Dr. Ankur Kalra. He does a phenomenal job with it. And so in this episode, we have discussed the history of neurocardiology, defined the different ways that the minds and hearts interact, and had a phenomenal conversation about the interplay between neurology and cardiology. Thank you so much for listening, and if you enjoyed this episode, please leave us a review and share it with a friend. Make sure you follow us on social media at Neurophilia Pod for updates on future episodes. Our next episode will feature dermatologist Dr. Elliot Mostow as we discuss the relationship between neurology and dermatology. See you next time.